Good afternoon, everyone. Before I begin, I want to thank Dr. Arity for her outstanding leadership throughout this fight. Our city would be in a much worse place without her and her incredible team at the Department of Public Health. They have all stepped up in an amazing way during this time. We owe them all a debt of gratitude, so thank you. I also want to thank our many other leaders joining us here today, including our medical and faith communities, as well as from the Chicago City Council. We are all in this crisis together, but we are not experiencing this crisis in the same way, and that's what today's conversation is about. While all of Chicago is grappling with COVID-19, what we're about to hear from Dr. Arity are the significant disparities in cases and deaths across our city. Dr. Arity will provide more details in a moment, but the bottom line is this. Among Chicagoans with COVID-19, for whom we have data on race and ethnicity, more than half are African Americans. The data also indicates there is likely significant underreporting within our Latinx community here in Chicago. And overall, some of our more culturally tight-knit communities may be experiencing a higher incidence of the virus, turning what should be a positive attribute into a risk factor. But as we can see from the maps that are up, this is not just about racial and ethnic disparities in the outcomes. The distribution of this disease tells a story about resources and inequality, a story about unequal health care access, job access, and community investment. Dynamics we know all too well here in the city of Chicago, and something that all of us have been talking about and fighting against for years. In a moment, I'll speak about how we plan to address the immediate and long-term challenges facing us. But first, I'd welcome Dr. Arity to provide further details about the data that we're seeing. Doctor?
Thank you, Mayor. I'll invite everyone to go to the website, chicago.gov/coronavirus. If you click on the tab Latest Data at the top, you'll see that there is much more detailed both demographic and geographic data than we've been sharing. And Chicago Department of Public Health will be sharing these detailed demographic data every day moving forward, being updated in the afternoon in conjunction with the governor's press conference. We'll also be updating maps 3 times a week and are testing maps weekly. So I want to give a little bit of context and more detail for COVID cases in Chicago residents. So among the 11,256 lab-confirmed cases in Illinois, 4,680 have been in Chicago residents. And out of the 274 deaths in Illinois, 98 have been in Chicago residents. All along online, you've been able to see that we have cases in every zip code. We have cases in children less than 1 and seniors of 100 years and older. But today is more about geography, demographics, and that means in Chicago, it is also a story of inequity. So let's start with age. From the beginning, we have been emphasizing the much worse outcomes that we see around the world in people who are older, over 60, even more over 70 or over 80. And I want you to know that that is just as true here in Chicago as it is around the world. So the data show cases in each age group, but especially where we look at those with more severe illness, hospitalizations, ICU, and deaths, we really see age. Fewer than 1 in 5 Chicagoans is over the age of 60. And just 1 in 12 Chicagoans, 8%, is over the age of 70. But almost 1/3 of Chicago's COVID-19 diagnoses have been in people over 60. And most strikingly, 71% of Chicago's COVID deaths have been in people over 60. And half of our deaths have been in people over 70. So again, 8% of our population in Chicago is over the age of 70. 50% of our deaths have been in people over the age of 70, reinforcing, again, this vulnerable population, the need to do everything we can to help protect people in the older age groups, the most important folks to be keeping at home and not interacting with folks outside the household. Secondly, underlying conditions. So again, from the beginning, we've been talking about the importance of underlying conditions as putting people at more risk for the severe outcomes from coronavirus. And when we look at our deaths in Chicago, though we're still finishing the investigation on 9 of the cases, among the other 89 cases, 97% had underlying chronic conditions, and 3 did not. Most common are diabetes, cardiovascular disease, including hypertension, and lung disease. So again, what we've seen around the world, we're seeing here in Chicago. Third, I want to talk about gender. While half of Chicago's confirmed cases have been in men, as you would expect, we're split 50-50 men and women as a society, 63% of Chicago's deaths have been in men. And this is actually also consistent with patterns we've seen around the world. We do believe there are some biological differences between men's and women's immune systems that play a contributing role. You can watch my Facebook stream as we'll talk about that some more. But studies have also shown that men, as compared to women, have higher rates of death from chronic disease, are less likely to seek medical help, are more likely to smoke, and actually are less likely to wash their hands and to use soap than women. We'll talk more about this, but I think it's important for men, and especially older men, to hear this, and for their spouses and family members to hear this, to ensure that you're being as careful as you can, keeping your chronic diseases in as best control as you can, not waiting if you're sick to seek medical care, and practicing the really important social distancing and hand hygiene. And then finally, I want to talk about the most important part of this data, which is geography and race ethnicity. So we have some maps, and again, you can see them on the website in more detail. But right here to my right is about Chicago's case counts by zip code. These are just the numbers of individuals in each zip code that have been diagnosed with COVID-19. And the darker represents more individuals. So you can see that down in the far south and southeast and up in the very north are where we've seen the most cases by zip code. But you can see some patterns throughout the city, not very dissimilar from other patterns that we see where we look at chronic diseases and other issues at the Chicago Department of Public Health. Online, you can see more information about the rates, where we actually correct the number of cases for the underlying population. So I encourage you to take a look at that. In addition, further to the right, we actually see our testing numbers. This is the first time that we're reporting these as well. So in Chicago, we've had approximately 15,100 cases that have been, 15,100 tests, that we've received results on. And within that, we've then had our 4,603 cases. We do think there are additional tests that have been done, but we're still having some issues sometimes getting negative test results back through the electronic system. And the health department at both the state and city level are working on this. But if you look at our testing rates, again, dark means more. These are just numbers of tests. And so you can see that we actually have had more testing similar in the same areas where we've had more cases. And that's because all along, where we've seen cases and the health department has been doing investigations, we've been working to bring testing into settings where it's most needed. Also doing that in congregate settings, like our long-term care facilities, our homeless shelters, our nursing homes, and people who are sicker, who are hospitalized, certainly needing ICU care. Those folks are absolutely all getting the testing. And so some of the higher positive rates that we're seeing are because we still do not have the widespread testing available in Chicago that we're hoping to see soon. So let's talk more explicitly about race and ethnicity. Here in Chicago, geography often is a stand-in for race and ethnicity. But if we look explicitly, At the Chicago Department of Public Health, we've been talking about not just health inequities, but racial health inequities for a long time. As part of our Healthy Chicago 2025 plan, we've really highlighted it around the 8.8-year life expectancy gap that we have here in Chicago. On average, a white Chicagoan lives 8.8 years longer than a black Chicagoan before COVID. What drives that gap? The biggest driver, more than half of that gap, is being driven by chronic diseases, cardiovascular disease, lung disease, smoking-related illnesses, diabetes. These are the very chronic conditions that put people at risk for severe illness and death. And if we look at some of that for just a second in black and brown communities in Chicago, again, forgetting COVID for just 1 second, diabetes rates among blacks in Chicago are double the rates of what they are in whites in Chicago. Lung diseases, deaths related to lung diseases like COPD are more than 20% higher. Almost 2 of every 5 black adults in Chicago has been diagnosed with high blood pressure, a rate 25% higher than whites. Almost twice as many black adults live with asthma as compared to whites, and almost twice as many black adults smoke. These underlying conditions are part of what are driving some of the racial inequities. But these inequities also reflect the conditions in which people live. Let's take diabetes. Even if we had a perfect healthcare system in which anyone could access a doctor, anyone could get the medications they needed, we didn't have any of these access issues that we're constantly working on, we would still see significant health disparities. That's because in many of our neighborhoods, it's hard to access healthy food because of high cost, few grocery stores. We don't have equal access to safe, walkable streets. People living in higher stress environments where there may be more exposure to violence, or people who are working multiple low-paying jobs to make ends meet. And fundamentally, the community conditions, the holes in our social safety net, differing economic, educational opportunities, and fundamentally the systemic and institutional racism that have driven these inequities over the years, we are now seeing play out in our COVID data. So let's talk about the rates. First of all, as a city, Chicago is 33% white, 30% black, 29% Latinx or Hispanic, and 7% Asian. Among those for whom race ethnicity is known, as the mayor said, 52% of our COVID diagnoses have been in black Chicagoans. 30% of Chicago is black, 52% of our cases have been in black Chicagoans. And most strikingly, 72% of our deaths here in Chicago residents have been in black Chicagoans, though again, black Chicagoans just make up 30% of the city's population. This last graph on the right here points to the differing death rates, where we see that the death rate right now in the cases that have been reported for non-Latinx blacks in Chicago is 7 times the death rate as it is for white non-Latinx. And you can see where Latinx, Asian non-Latinx, and other non-Latinx fall in. Much more detail, again, available on the website. But by and large, this is not, I'm sorry to say, a surprising story. It is one that demands action in a short-term way and in the way that we will be working on for decades to come. And I can think of nobody who has already taken a stronger stance on this, who has been a supporter to the Chicago Department of Public Health as we talk about this, and has been focusing on the poverty agenda and what it means to truly address inequities in Chicago than Mayor Lightfoot. I'm going to turn it back over to her to really go through some of what we together as a city need to do urgently to get this news out, to reinforce the science, and to make sure as a city we're doing everything we can to help get ahead of this.
Those numbers take your breath away. They really do. This is a call to action moment for all of us. When we talk about equity and inclusion, they're not just nice notions. They are an imperative that we must embrace as a city. And we see this even more urgently when we look at these numbers and this disparity. It's unacceptable. No one should think that this is okay. And we have to step up in this moment and step into it. As Doctor said, we've been talking about these issues for years, and we've been taking small, medium-sized steps to rectify the problem. Now is the time where we have to embrace this wholeheartedly as a city and take concrete steps to move forward. We're not going to reverse this in a moment, overnight, but we have to say it for what it is and move forward decisively as a city, and that's what we will do. This is about healthcare accessibility, life expectancy, joblessness, and hunger. No, this isn't a problem that's unique to Chicago. We're seeing this manifest in large urban areas with large Black populations all over the United States. Milwaukee, Cleveland, Detroit, and other places are experiencing the same thing, but we are going to step up and do something about it. Less than 2 months ago, I proclaimed that before all Chicago, that poverty is killing us, literally and figuratively. That reality was just as true 10, 20, 30, or 100 years ago, and it is here on our doorstep today. In this crisis, we are seeing just how urgent the issues of equity and opportunity are in Chicago. They are literally matters of life and death. Just as we heard while we were making strides in slowing the spread of COVID in our city, the numbers continue to rise and will continue to rise in the coming weeks. And as we see from these maps, the numbers are weighted more heavily on the south and the west sides, and among our most economically vulnerable communities. As such, many of these same communities suffer from an array of pre-existing health conditions which make them particularly vulnerable to this virus. We know that due to some of the economic barriers in communities, social distancing can be difficult, if not impossible to achieve, at home, on public transit, and essential businesses like grocery and corner stores, and we must solve that too. Our challenge right now is to immediately address this issue. We can and we will organize a rapid, coordinated, community-based, and community-driven response to what we are seeing so that we can mitigate the impact of COVID-19 in our city, and particularly as it is playing out and devastating Black Chicago. First, we must begin with the data. While we have sufficient data to see that these trends are alarming, as Dr. already noted, healthcare providers are still not providing total demographic information that is needed for us to have a complete picture of the impact. That must change. That's why Dr. Already will issue the COVID patient data health order. This will require healthcare providers to collect and give Chicago's Department of Public Health a complete suite of demographic information, including race and ethnicity, for each COVID-19 patient that they test or treat. This is not negotiable. We must understand the magnitude of the impact of this virus on all of our communities, and it is up to the healthcare providers who are on the front lines not to skip over the boxes that provide us with the demographic information that's essential for us to understand the impact on Black and brown communities. You must do this, and we will order it to happen. CDPH will also continue to closely monitor and make this data transparently available and commit to a regular cadence of releasing this data publicly so we can all see it. We can all see the progress or lack thereof. Second, in partnership with the great team from Westside United and led in part by this city's Chief Equity Officer, Candace Moore, We will be creating a leadership team consisting of public health experts, personnel from provider networks, and local community activists and stakeholders to form a racial equity rapid response team. I want to thank Westside United and their executive director, Aisha Jacko, for stepping up in this Herculean way for our city. Westside United has a model that works, and we will deploy it throughout the West and South Sides to help us address this issue. I want to also thank and acknowledge AARP for stepping up and offering to activate its vast network to assist in this effort. This will be a hyper-local, tactical effort to reach vulnerable people, educate them about options where necessary, and connect them with services to help fight the spread of this disease. And the outreach will focus on those over 50 and those with underlying health conditions. And the supports will include symptom monitoring, testing, and proactive healthcare engagement. And this team will be integrated into the city's Emergency Operation Center, just as all of our other working groups have been fighting day and night to fight this disease. As part of this outreach, we will be focusing our healthcare and hospital networks to double down on efforts to engage vulnerable populations and seek new solutions. What that means simply is all the doctors, the nurses, the nurse practitioners, the healthcare providers out there, when you know who you're serving, you know what a vulnerable population looks like. We need you to step up even more to make sure that we are doing everything that we can to reach, to educate, and to treat people that fall into this vulnerable population. We'll also be working with the Chicago Health Alert Network to promote direct and targeted communication between doctors and high-risk patients. This is an existing communication network for healthcare providers. We will re-emphasize the information and data around these vulnerable populations through this network. I'm also pleased to say that we are going to see insurance networks step up and mobilize their prevention information and resources with clients, particularly high-risk policyholders. And finally, we will institute a suite of policies to directly impact the most at-risk communities and address day-to-day challenges. We have to do this in connection with all of the other things that we're doing to emphasize and enforce the stay-at-home order. This will include, in a, again, hyper-local matter, make sure that we're increasing our surveillance of CTA bus routes across the city and adding larger and additional buses to promote social distancing and reduce overcrowding where needed. The CTA has stepped up to do this, and we will continue to move forward in that direction. It will also include taking steps to strengthen social distancing in our grocery stores and corner stores. We've heard reports across the city, particularly on the south side, where some retailers are not advancing social distancing as they must. We are sending inspectors out. We will demand that you do this, and if you do not, we will shut you down. This will involve increased education enforcement from our Department of Business Affairs and Consumer Protection. We are serious about this. We have to move forward together as a community, every aspect. Nothing can be spared. We all have to be in on it. We have to make sure that we're doing everything we can to enforce these orders. We can't simply stand by and let this disease wreak havoc in our communities. Lives are truly at stake. We have to see marked improvement in this data, and we need all of your help to do it. We need to support each other and hold ourselves accountable. We want Chicagoans to reach out with any questions or to report any problems that you are seeing. You can reach out by calling 311. Reach out to your alderman's office. Talk to your minister or other trusted community leader. We have to be in this together. And that especially goes for our communities that are most at risk. We will be here, we will support you, we will do everything we can to make sure that Black and brown communities get through this virus with as little harm as possible. But make no mistake, today is a call to action. It is a call to signal that we are not going to tolerate these kind of disparities. The work that we're doing now is work that we will continue to build on in the months and years ahead to close the kind of disparities that are impacting in a negative way Black and brown communities over access to health and life expectancy. We will get our city back on track. And now it's my pleasure to introduce Alderman Rod Sawyer, the chairman of the City Council's Health Committee.
Thank you, Your Honor. Thank you, Dr. Awadi. This is a concerning time for all of us. As we like to think, viruses know no wealth, know no race, know no condition, but the data seems to appear otherwise, especially here in Chicago. I'm going to ask everyone in Chicago, particularly the Black community, pay attention to this. This is real. This is very, very serious. To the extent that you can, this is not a practice anymore. Commit to social distancing. Commit to washing your hands. These are things that we can do to help contain the spread. The city of Chicago is doing their part. We're going to continue to do and step up our efforts, as Mayor Lightfoot said. But quite honestly, Mayor Lightfoot and Dr. Awadi were on this months ahead of time. Talked about the intersection between poverty and affliction. These things are now coming to roost right now, and we have to do something about it. A lot of it is within our control. Commit to the social distancing, but at the same time, let's also do good deeds. Without violating the social distance space, check on your neighbors, particularly those that are elderly and may be infirm. Check on your family members. Put a call in. I particularly like what Mayor Lightfoot's been doing with the memes and with the short ads that she's providing. We know this is a serious issue, but we have to take this and understand that we're going to come out of this, and we are going to come out of this stronger. But it's up to all of us to make that commitment, to do what's necessary, to isolate ourselves for a little while longer. It's been approximately 21 days now. Let's continue it going forward. Let's keep our space, keep our distance, but keep our connections with everyone. Let's make sure that we reach out to someone, maybe someone you haven't talked to in a while. Let's check up on everyone, but at the same time, let's be vigilant in this, and we will get through it. And I'd like to thank particularly Dr. Awadi and Mayor Lightfoot for their continued leadership in this effort, and let's keep going. Thank you.
I tore down the run of show in my haste, so let me see who's next. Aisha Jacko.
Good afternoon. I'm proud to represent Westside United and many organizations who are partners in our effort to address the entrenched inequities that exist regarding the life expectancy gap in our city. Thank you, Mayor Lightfoot, for allowing us to participate. For those of you who are not familiar with Westside United, our mission is simple. It's to build community health and economic wellness on Chicago's West Side by building healthy and vibrant neighborhoods. Our goal is to decrease the 14-year life expectancy gap between the Loop and 10 West Side communities by 50% by 2030. And our partners include the faith community, our healthcare institutions at Westside United, federally qualified health centers, education providers, business, government entities, and others that are working with us to coordinate our investments and shared outcomes. The mortality rates from COVID-19 are staggering but not surprising. At Westside United, we call our approach to health improvement Live Healthy Westside. Our Westside United Metrics Group has identified hypertension as the leading cause of premature mortality in African American and Latinx communities. Our teams have focused on hypertension management in 10 Westside neighborhoods, the same ones that are hardly hit due to COVID deaths in recent weeks. High blood pressure is one of the risk factors that contributes to this mortality, as we know. And we need not only look at what mortality from AIDS and the heat wave in the 1990s impacted vulnerable people on the west and south sides to understand the urgency of our work and why it's important that we come together at this time to work as one. The current COVID epidemic serves to further illustrate the urgency in addressing the underlying roots to poverty, educational deprivation, structural racism, and we are eager to work alongside Mayor Lightfoot and her team in public health, as well as others, to rapidly move the needle on the critical metrics across our not only West Side target communities that represent 10, but the other 67 communities across Chicago. When we consider the underlying premise for both West Side United and the Mayor's Invest West South campaign, they're based on the same optimistic and uplifting premise, that we can overcome poverty and eliminate death gaps when we focus our efforts together. Let's take some time to really think about how we can work together and coordinate an approach. Our suggested next steps are that we look at data. How do we convene a super data team comprised of CDPH, Westside United's Data and Metrics Work Group, and epidemiologists from our Westside United institutions? How do we take a public health approach to addressing this disparity? How do we mobilize our health systems that have already been at the table for the last 3 years, thinking through the life expectancy gap? We have reached this urgent time where we also need to touch bases with our community and make sure that we are leveraging the existing efforts that are happening on the South and West Side, but that we think about how we mobilize our community warriors as volunteers. We want to screen our vulnerable populations and triage them if possible, but we can only do that with a model that is coordinated across all sectors working together. So as we think about this approach to expedite what needs to happen with Westside United's approach around bridging the life expectancy gap, it is a hope that is true for our entire city. And we hope to use this approach to improve the health of the entire community. And we want to make significant progress in erasing the mortality rate disparities. We want to decrease the life expectancy gap from neighborhood to neighborhood, zip code to zip code. And together, we will make this difference. No one should have where they live determine how long they live.
That's right.
Thank you.
Thank you. My friend, Reverend Marshall Hatch, a
Thank you.
great leader
Thank you, Mayor.
on the West Side.
Well, we would like to, just with our time we have, to maybe lend a human face to some of these statistics. Probably last Tuesday, I got a call from one of the family members of our church. A man had died, had breathing problems underlying his previous heart condition. He was 62 years old, happened to have been my best friend, also a member of the church, but a friend for almost 45 years, high school, college, and that was Tuesday. Meanwhile, I got a call Wednesday from another family, and this was a mother of our church, Daisy G., who passed away, and we're not clear whether or not that was COVID related, but we were certain the previous death was. Meanwhile, my sister Rhoda, who was my oldest sister, who was 73 years old, was on a respirator at Loyola Hospital, and then her 8th day was Friday, and then early Saturday morning, we got that call that she had passed away, testing positive for COVID. And the challenge that our family has had to grieve while being socially distant has been added to the difficulty. And then by Saturday afternoon, I got another call from family of our church, young man about 55 years old, self-employed, had done a lot of work around our church over the years. Often we had to track him down in order to pay him. He was really a great guy. He passed away COVID-related. And so these are real human beings with human stories. And as a pastor, I was challenged to preach through my virtual sermon on Sunday and then get through communion virtually on Sunday while helping these families to plan for memorial services where we will have to be socially distant as well this week. And so, the pain is real, and we, of course, know that obviously it has been something that has come to our community in such a way that magnifies the already existing disparities in health care and access to health care, a community with the underlying conditions because of being in communities that are already struggling. And so I think Dr. King said that we commemorated this past weekend his memory, that out of all of the disparities that are caused by the inequities in our society, healthcare might be the most inhumane. And I think this pandemic of 2020 magnifies that truth that he's expressed over 50 years ago. So we do want to thank the mayor for highlighting nationally the issue that poverty is not just about quality of life, but it is about literally life and death. Poverty kills. And so in that we can address it, we become our best selves. And so we want to thank you, Madam Mayor. I want to say that, it is very comforting, not a meme, but to actually have the mayor looking over your shoulder at this time. We want to thank you for the work that you've done. Thank you.
Doctor.
Good afternoon, and thank you, Mayor and Dr. Awardi, for having me be here. My name is Toyin Adeyemi. I'm an infectious disease physician who has practiced in the Chicago area for over 20 years. And I'd like to start by offering my condolences to the families who are going through a lot of pain. And as we all know, for this virus, this COVID infection, we're all going to be infected or affected by this virus. We've seen the data, we've seen the numbers, but those numbers are humans and people. And for someone like me who's been in care, providing care for 20 years on the west side of Chicago, the data are sad. They're depressing, they're discouraging, but unfortunately not unexpected. And we talked about this. I'm really glad to hear about all the work and the stuff that we're not just presenting data, but we're talking about action and using the community and mobilizing everyone to do this together. Why was it not unexpected? Because we've seen those disparities with HIV and hepatitis and asthma and diabetes and cancer and all the things that we've seen. And so this was just layered on top, and it's happening quicker because we're seeing people die in a couple of weeks. So we're seeing the effects of these disparities. And we know that we talk about equality, but we have to go beyond equality to equity. Equality is giving everybody the same thing. Equity is giving people what they need to achieve the same outcomes. And we do know that our populations of color need additional resources, and I'm glad to hear about what's going on. Why was it not unexpected for me? Because we know that access to care is, for a lot of people, is fragmented, is intermittent, is limited, it's spotty, it's sporadic. People use emergency rooms for their primary health care. So when we got to a point where we told people to stay home, they couldn't get their albuterol inhalers, they couldn't get care for their conditions. We said stay home and call your primary care doctor. Well, people don't have primary care doctors. They didn't know who to call, how to call, who to reach. They didn't know how to do that. We talked about we're going to start doing testing and drive-through testing. People don't have cars. People use public transportation. We talk about presenting late. Well, people don't know how to do this. They get to the emergency room, it's already late. We've talked about social distancing. Social distancing for a lot of people is a privilege. Most people 1 out of 5 people, 1 out of 10 people cannot work from home, depending on what kind of service they're providing. They're working with individuals, they're taking care of babies, they're taking care of adults in long-term facilities, they have their own small businesses, so they're at risk and they continue to be out because social distancing is something that for a lot of people is a privilege. They're still on public transportation, serving in the industry. And then we also know that access to a lot of services is limited in some neighborhoods. People have to travel far. We know that when people call for ambulances, they have to have somebody get them in. They don't have cars. So those are all the reasons, in addition to some misinformation. So a couple of weeks ago, there was a lot circulating about Black people may be immune or not necessarily getting COVID. That was misinformation that we're putting out information to correct. But with that kind of misinformation, it allows some of the infections to lay ground in the community before we take action. We also know that sometimes there's an attitude of, this has happened, there's been so much disparity so long, this is just one additional thing. And it's important to hear the messaging today that the city and the mayor are taking this seriously and putting actions in place. This is not just number and data. This is a call to action to take it to that next level. So we know all the reasons why we're not surprised, but my call to action is to primary care providers, providers in the front line, everybody who's doing a great job in the healthcare workers, people in the hospitals, not to skip on information, be able to provide the data that the city needs to be able to get resources to the people who need it in a timely manner. Community mobilization, thinking about this is we. This is not them, this is not I. Protecting all the vulnerable in our society, not just by age, but by comorbidities. A lot of people do not understand or know that they have these comorbidities because they have no access to care. So my call is to the community is that while the city is putting things in place, while hospitals are putting things in place, while we're looking for increased access to testing and looking at community mobilization, to continue to stay home if you can. Social distancing, despite the need to connect, which we can do virtually, to stay home if you can, and to practice hand hygiene, wear your masks in public if you have to do, and really take that time to check on people, but even small gatherings. We know there are clusters and families and outbreaks, so it's important to, while we want to stay connected, this is important not to do that at this point, to stay home. Hand hygiene, masks when you can. Take your medications for chronic conditions so that your diabetes, asthma, blood pressure is well controlled, so you're in a better place if you do get ill. Have a plan for if somebody gets sick, how to take care, who's going to go out, who's going to take care of them. Stay home, but call and know ahead when you have symptoms, when to go in. Share good information. We talked about there's a lot of misinformation. Do not continue to share that. Look for credible sources. When you have resources that are helping, please share those with your neighbors, the elderly who may not have access to that information. And again, call out bad behavior. Like the mayor said, if there are people flouting rules, people not obeying stuff, people sneezing into their hands, people being out without masks when they're coughing, please call out bad behavior because this is a call to action. We are in this together, and we really have to do this together as a team. So thank you for having me, and thank you.
So I just want to reemphasize a couple of points that were made. Reverend Hatch said it really eloquently. This is painful. This is pain. But what I hope you see from the passion that we are exhibiting here today and what you'll see in our work in the neighborhoods is a resolve to do something about it. We're not just going to send you out statistics. We're not just trying to shock the consciousness. We are resolving as a city, as a community, to step up to do something about this. And the point's been made, but it bears repeating. All these numbers, all these zip codes, all these statistics, these are people. These are our sisters, our brothers, our mothers, our fathers, our children. We have to never forget that in this time, when we're talking about these cases and we're talking about hospital beds, someone, some family, some community is being deeply and irreparably touched in this moment. Let us be the balm that heals the wounds that have opened up in large measure in parts of our city. That is our obligation. That's our mission, and we will get it done. Happy to take any questions that you have.
There are a number of them coming in, as you might imagine. One of them had to do with the statistics and the number of data sets where you don't see the race. Do you believe this is due to just an oversight or deliberate intention not to put this information out there, or lack of information?
Look, I think people are doing the best that they can, but we need them to do better. And there's lots of different pieces of data that they have to enter into a system that then gets shared with CDPH and IDPH. And what we're seeing is they're skipping the demographic information. We just can't have that continue. Doctor?
Yeah. I'll just add a little more context, particularly where you're talking about, hundreds of cases coming in a day. We really are quite dependent on the electronic information that accompanies a lab result. And that comes with name and date of birth and address, and it should come with race, ethnicity. But if that has not necessarily been entered in the hospital system where that test is being drawn, or in the testing center or in the outpatient arena, we don't get it. And so we're missing race, ethnicity for approximately a quarter of our test results right now. And this is not that dissimilar from what we see at baseline, but for diseases that are not moving so quickly, the Chicago Department of Public Health goes back and tries to fill some of that in. We're talking to families, we're looking at other records, we're trying to correct any data that is missing from the medical record. But when this is moving as fast as it is, one of the reasons that we really put into order both a requirement for some more data sharing among hospitals so that the public health department will be able to more directly access information from the health record without putting that burden on the providers, who of course are so busy taking care of all the patients. It allows us to have better information about things like underlying conditions, and then importantly, putting a specific requirement on for demographics, including that you have to fill it in. It means that people need to ask also. We talked a little bit about the fact that we think that our Latinx and Hispanic ethnicity is underreported, and often this is because providers are in a hurry and it can be uncomfortable sometimes to ask someone what their race or ethnicity is, and we know from other studies that when you don't ask, you get underreporting, particularly of ethnicity. And so this is really in the middle of all the things that everybody's doing, we need Chicago's providers to take the time to ask the question and to ensure that it's entered, and then through that we're able to get the data at the health department.
What is just to that point, if they're going to be required, what is the enforcement and what's the penalty if they're not cooperating?
Yeah, so I think the biggest part of this is being able for us to actually have access to the electronic health record itself, because that allows us to have more information about a patient than literally just a test result on a name and an address, and it allows us to do some more follow-up. I think mostly, we put a requirement in place. There are penalties there. In the middle of the outbreak where we are doing all of the work that we're doing, I think unless we saw very egregious examples, like if we had a whole testing center, right, or we had an entire hospital, or then we would obviously be following up there and really making sure that that was in place. It's not that people are not trying to do the right thing. It's just sometimes it's easier to skip those boxes, and so we think by putting it into order, it makes the point that this is as important here in Chicago and everywhere as the name, the date of birth, the geography.
Mayor, got to bring up a question about a haircut this weekend. On social media, there's a lot of pictures going around, including a picture of you standing within just a couple of feet with no mask on, with a woman who said she got her haircut, or she cut your hair this weekend. Can you respond to that, please?
Yeah, I got a haircut. I'm in the public every day, and candidly, my hair was not looking the way that it did. I thought maybe I'd do it myself, but I knew that would be a disaster. But I think what really people want to talk about is we're talking about people dying here. We're talking about significant health disparities. I think that's what people care most about.
But Mayor, to the point, and also at Soldier Field today, you were seen hugging and taking pictures with people.
I'm sorry?
You were seen at Soldier Field today, taking pictures of people standing very close, arms around them, as it was described.
No. I didn't have my arms around anybody. I don't put my arms around anybody. If somebody touched me, but look, I think we are trying to do the best that we can under difficult circumstances. I am practicing social distancing. The woman who cut my hair had a mask, had gloves on. So I'm practicing what I'm preaching and making sure I don't typically take pictures these days, but we are trying to do everything we can to emphasize the messages around social distancing, washing your hands, staying at home. But I, as an elected official in the public face of the city, need to make sure that I am out there and visible through this crisis. People expect me to be a leader, and that's what I'm doing.
Do you have any concern about the mixed messaging with you telling people in one of your skits, you know, might have to wait to get a haircut, but then you do? Is there any concern with mixed messaging?
Look, I'll answer this again. I'm the public face of this city. I'm on national media, and I'm out in the public eye. And you know, I'm a person who, I take my personal hygiene very seriously. As I said, I felt like I needed to have a haircut. I'm not able to do that myself, and so I got a haircut. You want to talk more about that?
No, I think you answered the question. Thank
Okay.
you.
Thank you.
Can you tell us about the plans with CTA?
Say it again? Yeah.
Larger buses. Does this
So-
mean people are going to be limited on how many can get on
Well,
a bus?
what the CTA has been doing has been, because of the systems that it has in place, it can monitor the amount of people that are getting on a bus at any given time. It can monitor the amount of people that are on a bus. So they took the kind of double extension buses that usually are on Lakeshore Drive, but the Lakeshore Drive traffic, not surprisingly, is down, and they've moved a lot of those buses to very heavy trafficked areas on the south side. So the CTA is continuing to very aggressively monitor what that looks like and to try to break up and provide more buses on the lines so that people can travel on the buses much more safely. You know, I've had a lot of conversation with people saying, why don't you just shut the system down? There's a problem with that for basic reasons. The very folks that we've been talking about who have to go out to work, who don't have cars, that need and depend upon public transportation to get access to basic services. If we shut down the CTA system, that would be catastrophic for lots of neighborhoods across our city. But what we are remaining diligent on is making sure that we are providing enough bus service, enough rail service, so people can practice social distancing. From the very beginning of this crisis, CTA also doubled the amount of time that it's spending cleaning buses, trains, the platforms, because we knew that this was going to be a major concern. So CTA has been very proactive. They will continue to be proactive throughout this crisis.
Turn it over to Mike.
Thank you. This question is from the Sun-Times, asking for your reaction to the following. The Sun-Times reported today that City Hall was not fully prepared for the crisis, even after going through the fictional Crimson Contagion exercise, that the unpreparedness it included lack of a fully functioning telemedicine system that allows for the diagnosis of illness remotely. That system remains a work in progress. Also, safely finding places to treat those who are ill, and most importantly, 6 vacancies in the emergency preparedness positions at the Department of Public Health.
So I saw that article, and unfortunately, there are a number of things that it didn't report, and I'll let Dr. Artie pick them up. What CDPH did was, which they should do, which is an after-action report that identified where they were strong and identified areas that they needed to build up. And most of the things that they identified as areas that they needed to build up, they actually addressed. Now, why that didn't get reported in the Sun-Times article, I think, is unfortunate, but I'll do it because I think I'm better positioned to do it. Our Chicago Public Health Department has done unbelievable work through this crisis. But more to the point, they are nationally recognized for their preparedness work. There's a reason why the federal government chose Chicago to have this exercise, because of the reputation and well-earned of the Chicago Department of Public Health along preparedness. They have carried us through this crisis because they practice on a regular basis because they are routinely procuring the kind of goods and products that are necessary to be prepared in this time of crisis. They have pushed out literally millions of pieces of PPEs, from gowns to masks to gloves, the whole works, out to the healthcare system, which is not their normal responsibility, and to our first responders. So any notion that we are somehow not prepared is completely missing the mark. And Doctor, I don't know if you want to add to that.
I do actually. You know, I did not have the chance to respond to that reporter. I was not interviewed for the story, and frankly, I was disturbed by the conclusions because I honestly did not recognize my department in what was written there. This comment about telemedicine, I have no idea actually what that is even responding to. My guess is it may have to do with some of the work that we were doing to get telepsychiatry in our mental health clinics, but it has nothing to do with what we do. We don't, that's not sort of part of our clinical role. And we don't have concerns about where to put people. That's what we do as part of the health system. I saw the comment saying that the health department could only say that it had trained its staff on the systems that we use for data management. It couldn't prove that we were using them. Well, we're using them without difficulty in the department. And, you know, I know that everybody is looking for an angle on this, but when I see the really strong work of the emergency preparedness program in particular at the Chicago Department of Public Health called into question, it really bothers me. The reporter, my understanding, did get a hold of our after action report, which is a standard procedure where we link through all of the things that went well and then we highlight things to work on, and then we work on them. And frankly, if all levels of government had taken this exercise as seriously as the Chicago Department of Public Health did, taken its after action and put in place the things that needed to be there, I think as a whole, sort of at a federal level in particular, we probably would be in a stronger place than we are now. But I would absolutely push back with the strongest terms that the Chicago Department of Public Health, particularly our emergency preparedness program, and particularly anything related to that exercise, was in any way lacking. It has been the basis for all that has gone well in this response, and we continue to use those plans as we are facing, you know, problems of a magnitude that were not even predicted.
Question from Politico for the mayor. The state's unemployment insurance system is struggling to keep up with applications. What do you think Congress should do to help accelerate that process?
Well, I think one thing obviously that'll be helpful is in the Stimulus 3, getting checks in the hands of people as quickly as possible. We've heard a lot of different reports of whether or not those checks are coming this week or whether or not it's going to take the Internal Revenue Service weeks to do that. But the thing to do is to get money in the hands of people. My sense from the governor's prior comments is that we need some additional supports from the federal government in strengthening some of the underlying services for unemployment. I know that this is a problem that's not unique to Illinois. I've seen reports of a state system elsewhere really struggling to keep up with the massive volume of claims and claimants. But we need, on this area, I think, a lot more support from the federal government.
Question from Bill Cameron. Leaders have tried to eliminate poverty for generations. Why will your approach work? Well, because I think we're really resolved and determined to make sure that we do it. I mean, how often have you heard a mayor of the third largest city in the country or a mayor of any size talk about poverty and make a commitment to try to eliminate it within a generation and then devote time and resources and focus at the highest level to making sure that we do this. So poverty is not a secret in our city. It's been here for decades. But the difference is we are committed to doing something about it, to wrapping our arms around people all across the city in every neighborhood, calling it what we see and not shying away from it and saying, this is a problem that's too big. We can't do anything about it. The future of our city, in my estimation, is tied to how we address this most challenging of problems. If we do not
see people in neighborhoods who are struggling to eat, to have shelter, to get access to basic health care. Many of the things that we talked about today, if we do not focus on that like a laser beam, we will have failed as a city. Not failed just those people, but failed as a city. This is an imperative that we must reckon with and address. So I'm determined to lay the foundation right here, right now, to make sure that we are moving forward on this pressing issue. What we've talked about today around these healthcare disparities is a manifestation of the absence of food, of shelter, of healthy alternative choices, the absence of peace and safety in our neighborhoods. All of those things aggravate the poverty that we are seeing that plagues too many people and holds us back from reaching our destiny as a city.
Question from Tribe. A lot of times, because of the wealth gap, Black Chicagoans do not have the luxury to quarantine or isolate themselves if experiencing symptoms of COVID-19. What should folks do if they live in congregate settings or in homes with lots of people or family members? What should grandparents or parents who house lots of family members do to protect themselves?
Well, I think I'm going to refer to the doctor, and Dr. Adime really, I thought, expressed that very eloquently. Doctor?
So, yes, thank you for bringing that up. And that was why we talked about the importance of while we talk about social distancing, which is really important, how hard it is. I have colleagues and healthcare workers and physician couples who one partner stays in the basement, stays in the garage, takes off their PPE and doesn't get to go in. They've been doing this for weeks because they have the luxury of a 3, 4, 5-bedroom home, and they're doing this. We have the same workers in the healthcare system who are doing other jobs in the healthcare system that have forward-facing contacts. We're still going to the grocery stores. Who's staffing those grocery stores? Who's doing our deliveries? Who's delivering our mail? Those people don't have the PPEs necessarily, the gloves, the things that they need, and so they don't have the luxury when they go home to take stuff off and live in the basement and have Uber Eats deliver. Somebody still has to go to the grocery store. We didn't talk about how when there was the stay-at-home order and shelter in place, that people who had income went into the grocery stores and bought out everything, ordered everything, went to Costco. Some people need to buy stuff every 2 days because their income comes in daily or every 2 days. So when we hoard and we take things out by the first of the month, people had nothing to buy. They have no cleaning supplies to actually do what we need to do and clean around the house. So we really need to talk about when people see on the news and they see people on buses, I'm glad we're going to do social distancing, that some people do have to go out, and hopefully we can put things in place. Regarding the quarantine, things that have worked in other places are when people are ill, they're able to, if they're not in an environment where they can self-quarantine, there are in other countries, they've put them in places where they can be quarantined safely for 2 weeks until they're able to go back. We don't have that necessarily in place, but there are things that are being done to look at having healthcare workers and people in healthcare workers stay in hotels while they're working so they're not going back home all the time. It's hard. That's why it comes up with making a plan. If someone does get ill, who's going to be that one person who's having the most contact? You know, we talk about the vulnerable in our population, thinking about grandma or anybody in the home who has diabetes, high blood pressure, as being at risk, and who's going to be the one person taking care of them. Sometimes there's just one bathroom. We talk about having that person have a room, have their own bathroom, so that their toiletries, their disposables, their tissues are being taken care of. Sometimes you can't do that. We're more likely to have multi-generational families with people with different medical conditions in the same home. So we just have to, families, when we talk about having a plan, who's going to be the one person that goes out to do grocery? And when they come out, how do they kind of clean everything before they immerse with everybody else? If someone does get sick, who's going to be that person who's going to be in charge of them, and trying as much as possible to isolate. If there's a way to put people in places where if they're ill, we do that with tuberculosis, and Dr. Awadi can talk to that. When we're in the hospital and we have people with tuberculosis, when they are smear positive or even when they're converting to smear negative, before they leave the hospital, we decide who are you going home to. We do that for any infectious disease. If they're going home to a baby under 2, somebody on steroids, any immune condition, we keep them in the hospital. We try and find placement. We don't send them home because we know about who's at home. Sometimes that's what's happening. People don't have the luxury of self-quarantining within a home where there are multiple people, apartment complexes where there's shared space. People have to go do their laundry in the one room downstairs. So they're doing all their best within their home, but they're doing that. So when we talk about calling out bad behavior, even within apartment buildings, for people to say there's only going to be 2 or 3 people in the laundry area at one time, we're going to wipe down surfaces. And that's why I say it's a we and us approach, not just individual approach, because sometimes there is no luxury of being able to stay in the basement until your 2 weeks are off, or in a separate wing of the home, because people are living together. But I think that things are in place, and with our Westside United partners being able to actively engage with people, get them the services. And the mayor talked about the healthcare providers asking, we know who those vulnerable people are. So when people are being tested and they're being sent home, who's at home? Who do you live with? Have they been tested? Who else is at home? Those are questions that we should be asking as we're doing the testing and giving people their results. And even negative results, telling them, you're negative for now, but the disease is out there. Continue to practice social distancing and things like that. We didn't even talk about who's working the nursing homes. And the people who are providing care to the elderly in the nursing homes, a lot of them are really in these communities that we're talking about. So.
Thank you.
Can I?
Dr. Hardy, yes,
Yeah, thank you very much. That was great. Just to fill in a little bit more detail around the isolation and quarantine. So we've, every day we've been talking about all the new things that are happening and all of what's available. But I do want to remind people that we have isolation and quarantine facilities in hotels here in Chicago open now. Every hospital actually has a COVID discharge coordinator to be asking those kinds of questions. And if there is someone who is, in the emergency department or in the hospital, and for whatever, who's having symptoms, and for whatever reason, they're not able to return home. Maybe they don't have a home to go to. We've been doing a lot of work with the homeless population. Maybe they would be returning to a setting where they would be living with in a dormitory or some sort of living situation with a lot of people that wouldn't be appropriate. Or if they have vulnerable people at home and they're worried about being able to go home, they can go to one of these hotels to wait for a test result, or if it's positive, they can stay through the time of their infection to help protect others at home. So that is access through all of Chicago's hospitals, and it is available. So just wanted to add that piece in for awareness. Mm-hmm.
Last question for the mayor.
I got a follow-up too that I overlooked in my comments before, if I may. You had brought up at your press conference at Soldier Field about CPD breaking up large groups, meeting in very small arrests. Could you be any more specific on that, and especially heading into the warm weather we're expecting tomorrow? What exactly are these people going to do?
Well, we can get you the specific numbers, but I believe the number is around 11 citations and some smaller number of arrests. CPD is being very, very diligent, and for the most part, people are complying, but there are pockets here and there in the city where we still continue every single day to see people that are gathering in congregate settings. And that's the thing that's important. We're not saying people can't go outside. We're not saying people can't walk down their block and get some fresh air. It's important for people to do that. The problem is excessive congregation, way too close to people. That's where we have concerns about the risk and germ spreading. And that's the issue.
And one of the things that was also brought up in conversation with colleagues is that with all the parks closed, with the lakefront closed, you're pushing more and more people into the neighborhoods. They have to walk in neighborhoods because that's the only place they can walk. And so there's more and more people coming in close contact. Is it just
I have not seen that, and I drive around to different parts of the city quite a bit. Do I see people walking down the street, walking their dog, jogging? Yes. But I think for the most part, people are complying with the guidance that we've been giving, which is don't congregate in large settings. That's the issue. The issue isn't the exercise. The issue isn't being outside. The issue is congregating in large settings that put you and other people at risk of catching or spreading the virus. That's the issue.
Last question, Mayor, from the Daily Line. This morning you said you saw a tiny pinprick of light at the end of the tunnel. Mm-hmm. What is that based on?
Well, it's based on the data, right? We're seeing, I think the stay-at-home order went into place on March 16th, and I believe that this has been reported. At that time, we were seeing a doubling of the number of cases every 1 to 2 days. then it's moved to every 3 to 4 days, and now we're in a phase where it's about every 9 to 10 days. That's small steps towards progress. But that's why I said it's a pinprick, a very small light at the end of a long tunnel, and we're still very much on the journey. We're going to continue to see the number of cases go up. But as we've talked about before, we're following the number of ICU beds occupied, the percentage of those beds occupied by COVID patients under investigation for having COVID-19. Those are the numbers that we're watching very, very closely. And obviously, we're also concerned about when we see the surge happen, about our hospitals being overrun. That's why we put in place the hotel rooms. That's why we put in place and are working on the alternate care facility at McCormick Place. This is all about preparation and letting the data really drive what our response is to this crisis. And the data that we're here to talk about today is data about the huge disparities in the Black community across the south and west sides of Chicago in particular, and our resolve to make sure that we do something to address it immediately.
Any plans for a curfew of either people and/or businesses?
No, I mean, I don't think that we need that yet, although we are looking at certain kinds of businesses where we're seeing an excessive amount of gathering. You know, as we said from the very beginning, we're trying to educate people into compliance, but if we can't get that, then we'll take some additional steps.
And there may,
I'm sorry?
Are you talking about liquor stores?
Liquor stores are definitely an area of concern all over the city, so we may be taking some steps to address that. But do we need an overall curfew? I don't think so, because the vast majority of the Chicagoans, I think, have gotten the message, are staying home. They know that staying home saves lives, and they are compliant. But there are still some entrenched places in the city where we've got to step up our efforts to really drive home the message that you cannot congregate. You congregate, you are risking yourself, and you're risking the lives of other people. Thank you very much.